All right, we will go ahead and get started, recognizing it's a couple minutes after the hour. My name is Kristen McGovern. I am the Executive Director of the Partnership to Empower Physician-Led Care and a partner at Serona Strategies. I want to thank everybody for joining today. We know there's a lot of demands on your time, so we really appreciate that you are here to hear from our distinguished speakers on their latest research and to discuss the important issue of competition in the healthcare system. So I, as I mentioned, am the executive director. If you want to go ahead and move through the slides of the Partnership to Empower Physician-Led Care. We are hosting the briefing, but certainly the stars of the show here are Doctors Scheffler and Whaley, who we will hear from a little bit shortly. If you advance to the next slide, I'll quickly go through the agenda. And so the plan today is just for some brief opening remarks. We will turn it over and have presentations from both of our experts here. And then we plan to leave about 10 minutes at the end for some moderated questions. If there are questions that the audience that you all have, please feel free to go ahead and send those in over the chat feature here at the bottom. We will be monitoring the chat, and we'll collect those questions and address as time permits here at the end of the presentation. Next slide. So before we turn it over here, I just wanted to say a little bit about the Partnership to Empower Physician-Led Care. You can see here our members are listed on this slide. We are a DC-based advocacy organization working to support independent physicians and independent practices and moving to value-based care, largely as a solution to the growing and growing rate and amount of consolidation happening in the healthcare system. So these organizations that you see listed here came together and said, obviously we have an issue here with respect to dwindling rates of independent practice, and what are some solutions? So instead of just hand-wringing about the problem, what can we do to put forward some solutions? And so our group is really focused on several priorities, and you will see those listed here on the next slide, really framing the concept around value-based care as a solution to increasing rates of consolidation in the healthcare market. So you can see here our policy areas that we focus on. I think the most relevant for today is that one of those middle buckets, addressing anti-competitive policies that level the playing field for providers practicing in a range of different healthcare settings. So while we certainly spend a significant amount of time focusing on value-based care models and advocating for a quantity and quality of models that is appropriate for independent physicians and practices, we also spend time thinking about and advocating and educating around those underlying policies that really provide the foundation for those value-based care models. So if you go ahead and go to the next slide, we can talk about just very briefly some of the work, next slide, that we've done in this area. We have been active in supporting site-neutral payments so that payment differentials, again, to the extent that fee-for-service serves as the foundation for many of the value-based care models, making sure that those payment differentials, next slide, are, the same across practice settings. So there has been some action, as most of you might know, from both the previous administration and the current administration to monitor and assess and take action to support greater competition in the healthcare markets. I mentioned earlier site-neutral payment policy, which is something that was done in 2019 with respect to Medicare clinic visits. This executive order that was released by the previous administration in 2017 also included a requirement for a report. The administration subsequently released a report with a series of recommended state and federal actions. And if we go ahead and go through the next slide, and I apologize, I'm just going fairly quickly here because I recognize you don't want to hear from me, you want to hear from our experts. But one of the things that we have done at PEPC here is to take a look at that report, and you can find on our website an analysis of the recommendations and the progress made since those recommendations were put forward. So we sort of adopted a red, yellow, green scheme to, assess whether or not, the action had been completed, whether there was some progress, but maybe not full progress, or, some indication that the priority had slipped further down on the list. So again, you can find that on our website, and we will tweet about it after this briefing as well. Next slide. So I mentioned the site neutral payment policy. I think we can go ahead and skip forward, but this is something that we were pleased to see happen in previous years, and believe, if expanded, could have a bigger impact on the competitive landscape, particularly for providers. Next slide.
Yeah, now I'm on a Zoom.
I actually think so. We have a bunch of slides here. There has been a lot of activity in this area. I mentioned some action that CMS took. I mentioned a previous executive order on competition. This slide summarizes a MedPAC report that has looked at market consolidation. I think if we advance through just fairly quickly the next set of slides, you'll see that there was also a more recent executive order on competition under this administration. So that came out in July, and was broader certainly than healthcare, but did include some healthcare components. And then the next slide, again, something that we are monitoring and considering as we move forward in this space, is the part of what the executive order did was establish a White House Competition Council, which just recently met this month. So Secretary Becerra, HHS Secretary Becerra, is the representative to that Competition Council, which is a cabinet level council. He has focused on drug pricing as a near-term priority for increasing competition in the healthcare sector. So that is certainly something that we will be monitoring and watching, and potentially a mechanism for broader action on some of those priorities that were identified in the executive order. We will make this slide deck available after the briefing. I just wanted to sort of set the stage on some of the things that have been done to date historically, and some of the areas that our organization, the Partnership for Power Physician-Led Care, have worked on with respect to this particular issue. So I think without further ado, I will go ahead and turn it over to our first expert. As I mentioned, we have Dr. Richard Scheffler and Dr. Christopher Whaley here with us today. And I will just briefly run through both of their bios, and then I will turn it over to Dr. Scheffler to share his most recent research and findings and some of the things that he is thinking about as he considers competitive trends in the healthcare market. So Dr. Scheffler is a distinguished professor of health economics and public policy at the School of Public Health and the Goldman School of Public Policy at the University of California, Berkeley. He also holds the chair in healthcare markets and consumer welfare endowed by the Office of the Attorney General for the state of California. Professor Scheffler is the director of the Nicholas C. Petris Center on Healthcare Markets and Consumer Welfare. He has been a Rockefeller and a Fulbright Scholar, and served as the president of the International Health Economists Association 4th Congress in 2004. Professor Scheffler has published over 200 papers and edited and written 12 books. So he will be our first speaker. I did want to go ahead and just also introduce Dr. Chris Whaley, who will be our second speaker. Dr. Whaley is a policy researcher at the RAND Corporation and the professor at the Pardee RAND Graduate School. His research focuses on using large-scale medical claims data to examine how information and financial incentives influence patients' choice of providers, how providers respond to changes in consumer incentives, and how employers and insurers can design insurance benefits to promote value. His research has been published in a variety of clinical, health policy, and economics journals. He is the lead author of a JAMA paper that examines the effects of online price transparency information. This paper was a finalist for the 2015 National Institute for Healthcare Management Foundation Annual Healthcare Research Award. He also received the 2015 HRQ Research Conference Directors Award for a paper published in JAMA Internal Medicine that examines the effect of reference pricing on consumer choice of providers for cancer screening services. So certainly we are pleased to have these distinguished researchers here with us today to help share their insights on healthcare competition. So with that, I will turn it over to you, Dr. Scheffler. If we want to go ahead and advance the slides, I'll bring you up on the video.
Okay. So can everybody hear me? I see the slides, but I don't see me. Is that okay?
Yeah, we can hear you and we can see the slides. I think I can see you. Hopefully others can see you as well.
Well, I can't see myself, but I don't need to see myself. So anyhow, as long as you guys are okay, perfect. So I want to thank Kristen for the opportunity to address her members of this partnership, which I think is quite important and a force in the healthcare field. I'm from California, so I'm going to talk about the impact of competition and consolidation, both in California and also the rest of the country. I'll try to hit the high points in the 15 minutes that I've been allocated, and I hope you'll find this interesting, if not shocking. So let's start with the next slide, please. So I'm going to run you through the following. I'm going to start with some recent data from a study that I published with Laura Alexander of the American Antitrust Institute on private equity investments in healthcare, the newest and most powerful trend in healthcare markets in the US. And then I'm going to show you some data on the impact of outpatient services. That basically is the closest measure we can get to physician practices, which most of the audience is a member of. And then I'll run you through quickly just some trend data on California, looking at the hospital markets, and then vertical integration. And then I'll talk about some of the big verticals and show you a little bit of information about how varied healthcare prices are across the United States. And then the impact of consolidation on these prices and also wages. And I'll just make a brief remark or two about what the next frontier is in healthcare consolidation. Okay, next slide, please. Okay, next slide, please. Thank you. Okay, so this is a rather busy graph, or you can look at it later, but I'll run you through some of the high points of it. This was a study, as I said, that I just published with Laura Alexander of the American Antitrust Institute. And this looks at private equity. These are big investors that are an important force of providing capital to the economy and also to the healthcare system. The dramatic change, by the way, that says 2010 to 2010, it should be 2010 to 2020. Sorry about that typo on the upper left. But what you can see is the number of deals that private equity firms have had have gone up 166% over this period. And the amount of investment in the healthcare sector coming from private equity firms over the last decade has gone from over 40 billion to 120 billion. Close to just under a 200% increase. And if you add it up over the period of the 10 years, there's been a $749 billion investment in the healthcare sector. So the healthcare sector has become a prime target for private equity firms and an important force in consolidation and impacting healthcare markets. Next slide, please. So here's the data I mentioned on outpatient services. And I'll give you the high points again. This sector of buying outpatient services or outpatient practices has had the most dramatic increase from private equity firms. As you see, what the data shows you is that over this time period, 2010 to 2020, the last decade, it's gone up 586%. They target particular specialties we've seen so far: dermatology, ophthalmology, pain medicine, women's health, urology, on and on. Now they're starting to move into buying primary care practices. So this is a dramatic force, and I'm sure many of the people on the Zoom have already been approached by private equity firms. I would caution you to be very careful before you jump into one of these deals. Next slide. So consolidation in the jargon is measured by something we call HHIs, or a Herfindahl index. And this is simply the measure of how concentrated the market is. The index varies from 0 to a maximum of 10,000. The Federal Trade Commission Department of Justice guideline says that when a market, the Herfindahl is over 2,500, which is the starting point on the vertical, that market is heavily concentrated and presumed to lead to price increases. And so what you can see for both California, the blue line, and the US for the red or orange line, that over this decade, all of these measures are highly concentrated. They continue to trend up, 7% in the nation and 5% in California, but they're already super concentrated. Next slide, please. So here are some data on what we call the small verticals. And this was alluded to a little bit in Christine's opening. And this is the issue in showing of hospital systems buying physician practices. And here I provide the most recent data available for both California and for the US. And so you can see in California that 52% of the specialist practices in the state are owned by hospitals or hospital systems, and it's just under 50% or 40, 45, 46% for the nation. So this has been a dramatic trend. You can see the slope of those lines, and this continues now and is accelerating in the pandemic, and we hope now post-pandemic, as a lot of small practices have had financial difficulties that I'm sure you're aware of, and financial challenges. And so hospitals and hospital systems are now offering to buy them and make them part of their hospital system. Okay, next slide, please. So I won't go into a lot of detail here, but there are what we call the big verticals. This is, for an example, just picking one, when CVS bought Aetna, the health insurance company, and there was a challenge to this big multi-billion-dollar merger, but it was not successful, and the merger was approved. Part of this comes about because the guidelines dealing with vertical mergers are in disarray. I put on the right a paper that you can click on and look at, looking at my view with Tim Greeny on how the vertical guidelines should be used in healthcare mergers and acquisition. But this is now in turmoil, and the Federal Trade Commission, Department of Justice, has reneged the guidelines of the previous administration, and they're now in a debate about what the new guidelines should be to judge anti-competitive behavior in vertical mergers. And it's hot and heavy. There's a lot at stake, and I do expect that it'll be resolved in the next month or two. Next slide, please. So this is just quickly to give you some sense of the variation in prices across the country. The dark states like California have the highest prices, but you can see there's huge variation in the prices. This variation correlates quite well with the degree of concentration in the markets that I showed you before. These are basically hospital prices, and they correlate quite well with the concentration in the marketplace for hospitals. On the right is a breakdown of the state of California. You notice the northern part of the state is quite blue, and that is a direct mapping of much higher concentration of the hospitals and healthcare systems in Northern California. This led to a landmark case that the Attorney General brought against the Sutter healthcare system. And this case was settled, just recently settled with $575 million penalty being paid for the behavior of the Sutter healthcare system using their market power to increase prices in Northern California. Next slide, please. So what we have found is not only the impact of prices for the consumer, but recent work shows that, and here you see the horizontal merger concentration in prices. This is done in California, and you can see the price increases. This is for a C-section, going up from 14,000 to 18,000 as the measure of consolidation or market power increases. We have a recent study we put out at the Petris Center called Vertical Integration of Prices. I won't go through all the jargon, but we find also good evidence that vertical integration is correlated significantly with increases in prices. Lastly, there's a paper I'm citing here on Arnold and Chris Whaley, my co-speaker, which is an outstanding paper. And this is the first paper to document the increase of hospital mergers on wages in the economy. So when hospitals merge and increase prices, this has a dampening effect on the wages of people who work in those industries, because in order for the employer to pay these increased prices, they have to do something about the wage rates, and they often have an impact on lowering wages for the workers in those industries. And so here you see this new piece of evidence of the impact of hospital consolidation, not only on prices and health insurance premiums, but also on workers in the economy. So I think I'm kind of done with my slides. Do I have another one, or is that it? No, I think I have a summary slide. So yeah. So this is what's next. At the Petris Center at Berkeley, we're working on this as we speak, but it turns out now that the merger activity, which is increasing at an increasing rate, is now moving across markets. What do I mean by that? I don't mean examples of this is the mergers are taking place across states, and about half the mergers are across states, or in California, it's a merger between a hospital in the northern part of California and the southern part of California. So these are not mergers in the same geographic area, but across wide areas. And some of the merger activity is actually across the country. This is not only in hospitals, but also more recently in health insurance companies. In California, we have an Office of Affordability, which hopefully will be put in place this year to try to deal with the impact of these mergers on the state of California. I think if it passes, it will be a national model. And I refer you all to Amy Klobuchar's recent hearing on competition and antitrust enforcement. And it was a special meeting on healthcare. And so it definitely looks like the Congress, the president, as Christine mentioned, having a competition council, and also state legislatures are all getting activated to deal with consolidation in the economy overall. But I can tell you that healthcare has a faster trend than most of the other industries that are going through this consolidation and merger activity. And the bottom line is it has a crushing effect on small actors in the industry and in the healthcare system, and particularly on small practices and independent practices of physicians. So I'll stop there and turn the floor over to Chris Whaley. Thank you very much.
Great, thank you. We will go ahead and bring up, there he is, Dr. Whaley.
Great. Thank you. And it's also really great to continue to learn from Richard. I did my PhD in Richard's program. One of the 200 plus papers that Richard has actually was, I think, my second or third paper, where we actually compared physician versus hospital-led ACOs and examined how independent physician groups maybe are better organizers of affordable care organizations or accountable care organizations. And so this is a topic that for both Richard and I has been really important and interesting for several years. Next slide, please. So just some housekeeping. RAND is a nonpartisan nonprofit research organization, and RAND does not lobby or endorse any specific legislative or policy proposals. Next slide, please. So as Richard mentioned, one of the really dominant trends in the US healthcare system is the rise of vertical integration. And so what we typically mean by vertical integration is when a physician or physician group is either employed or in the physician group sense owned by a hospital or healthcare system. And as we can see in this chart, this has been a trend that's been really pronounced over the last decade, and especially in the last couple of years has really spiked. And so what this study does is essentially look at national data that covers about 75% of all US physicians and physician practices, and look at trends in hospital employment or physician group ownership by hospital to health systems of physician practices. And across kind of all specialties, with the exception of dermatology, which as Richard alluded to, is maybe less a focus of vertical integration, but more of private equity activity. There's really been an increase in the share of physicians that are vertically integrated. And so this, just to pick an example, if we look at, say, oncologists, that the share of oncologist physicians in the United States who are vertically integrated increased from about 20% in 2007 to over 50% in 2017. And so anytime we see a line like this and know that the scope of healthcare in the United States and see a trend that just spikes like this, a natural question is, what's the impact of this type of activity, and how will this type of activity potentially reshape healthcare markets in the United States? Next slide, please. And so this is a trend that is both increasing, and if we think about what are the impacts of vertical integration, it's a somewhat complicated story. And so some of the work that I'm going to talk about today really focuses on the first part, which is how can vertical integration impact prices or spending for healthcare services. But there could also be other more beneficial impacts. And so if hospitals or physicians rather are vertically integrated with the hospital, then maybe there's some sort of economies of scale. And so you're a large organization, maybe you don't need to duplicate developing your own EHR, or you can have a kind of centralized billing system. And so that could be a potential benefit of vertical integration. And there could also be other types of efficiencies. And so maybe if your EHR system is all linked, you know that a patient has received, say, already received an imaging test or a laboratory test. And so maybe there's fewer duplicated or unnecessary procedures. And so as we think about what are the impacts of just this huge rise of vertical integration in the United States healthcare system, it's really important to think about what are the trade-offs between what we know is happening on the market structure and price and spending side with potential benefits from care and efficiency. And so as I'll highlight a little bit and kind of jump towards the end, we know a lot or are starting to know more about the impacts of market structure and prices, but the impacts of vertical integration on efficiency and quality are right now a little bit still up in the air, not quite as known as well. Next slide, please. A lot of the kind of the early work on vertical integration really focused on the ability of physicians and physician groups to essentially negotiate higher prices with insurers. And so if you're a physician or a small group out there and you're sitting across the table from a large insurer, you're probably not having the upper hand in price negotiations. And so in many cases, maybe you just take whatever the insurance offers, or just has a blanket rate for physician services in the market. On the other hand, if you join up with a hospital, instead of you sitting across the table, it's this big hospital system. The hospital system probably has a lot more clout and can say, we want to get a higher price for our physicians and for our physician care. And so a lot of the early work on how physician vertical integration impacts prices really focused on that mechanism. But what I'm going to talk about today is a slightly different mechanism, and that's thinking about downstream care, and especially the differences in prices for many types of downstream care based on the site of service in which they're delivered. Site-neutral payments was mentioned earlier in the context of physician services, but it also exists in the context for many other types of services. And so just to highlight on the left-hand side, this is a study that we had come out in Health Affairs actually a couple of weeks ago, where we look at prices for common oncology drugs and compared prices for infusions delivered in a hospital outpatient department versus a physician office. And so this is comparing the exact same drug, the exact same dosage and units of drugs delivered. And what we found is that the exact same prescription or exact same infusion performed in a hospital setting versus a physician office setting was about 1.5 times more expensive than when delivered in the physician office. And so simply just taking a patient and moving them from getting their infusions in the physician office to the hospital is a potential way to increase revenue or billing for the hospital system. On the other side, on the right-hand side, we have a similar analysis that looks at not infused drugs, but actually colonoscopy provider prices in the state of California. Here, what we find is that for colonoscopies performed in a hospital outpatient department in the blue dots versus in the ambulatory surgical center in the red dots, colonoscopies performed in HOPD were about, again, twice as expensive as colonoscopies delivered in an ASC. And so there's both wide variation in prices that Richard alluded to across markets and across provider types, but one of the kind of big sources of provider price variations actually across different sites of care. Next slide, please. And so how might this kind of intersect with vertical integration? And so just to kind of illustrate that, I want to use the example of a patient getting an infusion. So if you have a patient and this patient receives their infusion in a physician office, we know that that's, it's a oncology infusion or a specialty drug infusion, it's still going to be relatively high priced. But if a hospital purchases the physician group and through either kind of formal or informal mechanisms instructs the physician to move that patient to the hospital, the price is going to roughly double. And so by shifting downstream sites of care, in some sense, this is an arbitrage opportunity, if you will, for hospitals and healthcare systems, where they can deliver the exact same types of care, but receive a price that's roughly double. And some of the examples I highlighted earlier for commercial insurers, but the exact same mechanism largely works for Medicare as well. And so across all these different types of vertical integration, if this very pronounced trend in healthcare leads physicians to shift patient demand from receiving care in hospitals, or rather in physician offices or ambulatory surgical centers, or even freestanding diagnostic testing facilities to the hospital, then prices for those procedures and spending on procedures will go up. And I think it's also important to recognize that this price increase is outside of what we largely think is the kind of the price versus innovation or access trade-off framework. And so regulating drug prices or thinking about drug price policies is a hot topic right now. A lot of the trade-offs involve the tension between paying more and potentially fueling more innovation on the manufacturer side. This type of activity is actually totally outside that, because the hospital or the physician office, if we look at infused drugs as an example, really just purchase the exact same drugs from the manufacturer. And what we see here happening is really a markup that impacts patients, but maybe doesn't go back to fuel future innovation. Next slide, please. And so when we look at the data, that's exactly what we see happening. So I'm going to highlight a couple of studies. First is a paper with a co-author, Michael Richards at Baylor University, where we've actually used all orthopedic surgeons in the state of Florida and actually looked at what happened when they were acquired by a hospital or health system or vertically integrated. And what we found is that once a physician or orthopedic surgeon was acquired by a hospital, then the share of patients that they actually referred to an ambulatory surgical center decreased pretty steadily and decreased year over year. Overall, there's about a 20% reduction in how many patients went to an ASC following vertical integration. Next slide, please. In other work, we've looked at the same type of mechanism, but looked at imaging tests and laboratory tests in the Medicare system. This is joint with Xiaoxi Zhao, Mike Richards, and Cheryl Danberg from RAND. And what we found is that when in the Medicare system, when a physician was vertically integrated, so acquired by a hospital or health system, the number of procedures that they did increased overall. And so per 1,000 beneficiaries that a patient or a physician saw, rather, the number of imaging tests that they delivered increased by about 1.5, and the number of laboratory tests increased by a little over 8. Most of the shift comes from actually reducing the number of tests done in non-hospital settings and doing procedures in hospital settings. But it is also notable that the overall number of procedures increased, which is maybe a little bit contrary to the claims of efficiency or the idea that if physicians are vertically integrated, they're going to do fewer maybe services that are lower value care, such as imaging and diagnostic tests. And because Medicare pays differently for services done in a hospital setting versus in a non-hospital setting for these tests, Medicare reimbursement overall went up. And so following vertical integration, the average test or the average reimbursement rate for a imaging test increased by about $6 and about 50 cents for a lab test. Now, these are, literally dollars and pennies per procedure, but in the Medicare system, literally hundreds of millions of these procedures occur. And so what we calculated is just for the 5 most common imaging and lab tests, Medicare spending increased by about $73 million. Next slide, please. And in ongoing work, we actually find very similar trends for overall spending. And so this figure looks at before and after a physician was vertically integrated, how much their patients had in total medical spending for oncology treatments. And what we find is that once a physician was vertically integrated, overall patient spending increased by about $400 for the patients they treat. And this occurs largely from shifting patients from care outside the hospital, care inside the hospital. Next slide, please. And then we have also found some evidence that vertical integration maybe plays a role in preventing or halting the diffusion of different types of technology. And so what we did in this paper is we actually looked at the growing trend of allowing procedures to be done outside the hospital for total knee replacements. And so there's been a lot of surgical and technological innovation that allow what was once a procedure that required several days of inpatient stay to being done in an outpatient setting, in many cases in less than 24 hours. And so if you think from a kind of a patient perspective, this is a really good thing. So instead of spending days in the hospital where potentially you can get more infections, and then also for a knee replacement, it's important to be mobile early. And if you're sitting in the hospital bed, you're not mobile, or there's barriers to being mobile. And the cost is also about half what it costs to do the procedure in the hospital versus an outpatient setting. And so we think that this is a good thing for both patients and for payers. And we found that in 2018, when Medicare, or 2017 rather, when Medicare authorized procedures to be done in an outpatient setting, there's really an explosion of procedures that moved from inpatient only to outpatient. And so again, this uses data on all orthopedic surgeons in the state of Florida, so certainly relevant to this audience. And so we find this huge spike for all procedures, which we've highlighted in the 2 blue lines. And so the light blue highlights physicians who are not vertically integrated. But the one kind of group that was perhaps left out is what we highlight in the green line, which is vertically integrated surgeons. If you're a hospital, maybe it's great that patients can get procedures done in an outpatient setting at half the cost, but that means half the revenue to you as a hospital. And so physicians who worked for a hospital were reluctant, or in our data, very reluctant, if you will, to move patients outpatient to an outpatient setting. Next slide, please. And so that is kind of a high-level summary of some of the ongoing work that we have on what are the health system delivery impacts of vertical integration. But I also want to highlight the impacts on physician wages. So this is also with one of Richard's students, or one of the researchers in Richard's centers. And what we've been able to do is look at what happens to physician wages before and after they become vertically integrated with the hospital. And so the red vertical line indicates the date, or the year in which vertical integration happened. And if you look at the lines to the right of that, they're all around 0. And so what we find actually is that physicians who become vertically integrated with the hospital or health system don't appear to be benefiting directly financially. And so I think a big unanswered question is, what really explains this rapid rise of vertical integration if it's not things like simply getting paid more? It could be that being vertically integrated or working for a hospital or health system really allows maybe the physician better lifestyle balance. So maybe they don't have to deal with the stress of running their own business, or it could just be technology barriers to, say, implementing your own EHR or dealing with insurers. And so I think there's a lot that remains to be explored on why physicians are undergoing this rapid vertical integration wave. Next and last slide. And so we know a lot on how vertical integration impacts the healthcare delivery system in terms of access to care and prices. But I think there are really kind of three areas that are not really known that well. So one, we don't know much about improved care coordination or efficiency. We also don't know if moving patients from non-hospital to hospital settings improves quality. Maybe hospitals have higher quality, and so this could be a good shift from a quality perspective. On the other hand, many non-hospital settings have really developed lots of expertise and have kind of the focus factory environment, if you will, that actually leads to better quality. And then if we kind of add these two up and combine it with what we've seen on the price side, we don't really have a good sense of what are the changes in net medical spending. And I really think that understanding how these impacts or these trade-offs really weigh up, and in some sense, again, looking at what are the total or cumulative effects of vertical integration is really critical for assessing what we know what's happening on the price side. Next slide. And so just, again, the same housekeeping. RAND is nonpartisan nonprofit research organization that doesn't endorse any specific policy proposals. So, next slide, I'm happy to answer questions.
Great, thank you. So that now we will follow up. I think there's a lot of food for thought and different directions we could go here with those two presentations. I'm going to go ahead and bring Dr. Scheffler back and bring myself back for the moderated portion of the discussion here. There we all are. Okay, perfect. And Caroline, if you would like to stop sharing your slides, I think we can just go with the video for now. So I think following up, again, as I mentioned, thank you for those presentations and a lot of food for thought there as we think about different trends across the healthcare system. I think it is clear that consolidation has been occurring even before the COVID pandemic, but certainly, would be remiss to think that the pandemic did not impact this trend just like it has impacted many other trends. So I wanted to start by asking you, either of you or both of you, how you think the COVID-19 pandemic impacted or will impact the pace of hospital consolidation or consolidation writ large. Are we seeing anything new? Are we seeing anything different? Is it just more or faster consolidation, or are we just on trend from what we were seeing before? Dr. Scheffler, did you want to go ahead?
Okay, I'll take the first shot now. So I think that the consolidation that Chris and I spoke about is increasing due to the pandemic, significantly increasing, especially in the physician area. And this is obviously due in part to the financial impact that the pandemic had, particularly on smaller hospitals and smaller physician practices. Of course, there was help in the CARES Act and others to help the healthcare system, but the vast majority of this funding went to large healthcare systems, and very little of it as a share went to smaller ones, hospitals and physician practices. So they're now in financial stress, and they're targeted for consolidation.
Yeah, I think just to add to that, which I totally agree with. The way I think of it is it's kind of a push and pull mechanism, and so the financial impacts and just the stressors of the pandemic, I think, were more acute for smaller physician groups and for smaller hospitals. And on the pull impact, as Richard mentioned, many of the financial assistance packages probably disproportionately went to larger hospitals and health systems. And then on top of that, many large hospitals and health systems have done well financially outside of their hospital business. And so there was a Wall Street Journal article yesterday, the day before, that really highlighted the returns of many universities. Many hospital systems and their endowments have had those exact same returns in the stock market in the last couple of years. And so that's really a war chest in some sense for a lot of this potential activity to happen. And so maybe we're not seeing it right now, but at least all of the other researchers that I've talked to have essentially said that this is something that in the next couple of years is going to certainly increase.
Great. So Dr. Whaley, your research showed that once physicians are acquired by a hospital, they're more likely to refer patients to other hospital services. How does this impact other healthcare providers in the region? You know, particularly those remaining independent practices.
Yeah, and so it certainly impacts it, and economists actually have a term for this called input foreclosure. And so what economists and regulators worry about is that if essentially a vertical consolidation event is moving patients to a hospital or health system, then that's in some sense capturing a stream of referrals that perhaps would have gone to both independent physician groups and also independent downstream providers. And so without those same type of, or that same level of referral patterns or this disruption to referral patterns, it certainly makes it harder for independent providers to stay in business. And then at the same time, because you're essentially moving downstream patients to a hospital or health system, you also have a horizontal change in market structure. And so a lot of the stuff that Richard alluded to. And so I think there's a concern, right? You know, the FTC has expressed a concern that vertical integration is de facto operating as a backdoor route, if you will, to horizontal mergers that would have otherwise been opposed.
Great. Dr. Scheffler, your piece really focused on some of the emerging trends and evidence around private equity. Can you talk more about this issue and suggestions on how we think about private equity getting into healthcare? There's actually a question on the Q&A about tech-enabled providers and providers with capitated payment models, many of whom are investment backed in some way, and how those types of players will impact the industry and costs. I'm not sure if you looked at that, but interested more in your takeaways on the private equity side of things.
Well, as I indicated and showed you slides, that's the biggest new force in the healthcare system, and it's particularly now focused on physician markets. And a typical private equity deal is as follows. A private equity firm will seek to buy a physician practice, and what its goal is to expand the practice and also to borrow as much as it can from the practice, run up debt, and then to sell the practice in 3 to 5 years. It has no motivation to stay in it for the long run. So it's basically flipping, as one would flip a house. It flips a practice and moves it on. So it has no concern about quality, patient continuity, the delivery of care. It's a financial mechanism. And the physicians in it get flipped along as well. And so physicians will be offered some amount for their practice. Some of them continue, some of the deals have them continue to work in the practice. Sometimes they also might be given some equity in the deal, say 10 or 20% of it. And so when the practice is sold, they would share in the profits. This creates, in my mind, a conflict of interest that physicians shouldn't have to face. And that is, making money for a private equity firm versus taking care of their patients and the stresses on them to produce revenues and profits, which are all good. Profits are not a bad thing, but the stresses on them to do this in 3 years or 5 at the outside, so the firm can be flipped or sold and make money, I think is just unconscionable, and it's not really what we want for the healthcare system.
Great. I want to ask another question we have here in the Q&A, and you know, and I'll just paraphrase, but I think it's a good one to sort of conclude on, which is if you're an independent physician or a practice out there thinking about the landscape and some of the trends, what, if anything, maybe you don't have an opinion on this, but what, if anything, could you do to ensure that you remain independent? So I guess another way of asking the question would be, if you're an independent practice, are there criteria that hospitals or private equity firms or others really look at to think about you as an acquisition target, or things that independent practices could do to you know, make sure that they stay independent, just as they're thinking about the landscape and the broader trends here? It might be a little outside the scope,
yeah,
but
so I think that's a hard question to answer. And you know, if we go back to my early slide, you know, the takeaway is that this is just a dominant trend in healthcare, and I think, you know, we don't really know kind of two things. So one is kind of the net, you know, if you take into account the price and the quality effects, is this, you know, beneficial or harmful, or what's the impacts? But then I think even more fundamentally, and this also gets back to what I highlighted when we've looked at compensation, why physicians are selling their practices, I think is a little bit of an open question. And I think that we actually have to, you know, in the research community, understand that a little bit more before we can say, you know, these are the, you know, the checklist, if you will.
I have a few thoughts to add to that, if that's okay, Kristen.
Yep.
So the small physician practices, I would advise first, look very carefully at what you're being offered from a hospital or private equity firm, and make sure that you get good counsel from lawyers and financial advisors before you sign on the dotted line. Secondly, try to talk to each other, and you might be able to maintain independent practice if you can join up together and be a force yourself. So small practices that form organizations and can work together, I think, have a possibility of surviving this consolidation wave. And then lastly, and most importantly, I would get involved at the state level, in particularly dealing with the regulators and laws that are passed that would scrutinize what private equity firms can and cannot do in your state. There are a number of states already doing this. The laws are changing. The attorney generals in various states are now on this issue, and I would make your voices known to the regulators and to the legislatures. And if you look, you'll see various states that are trying and have bills written to deal with these trends, and that would be extremely important for you to weigh in to what's going on at that level.
Great, good suggestions. And I would say, from the Partnership to Empower Physician-Led Care perspective, certainly one thing that we would suggest is to consider whether there's a value-based care model that works for you. So something that moves you away from a fee-for-service utilization-based payment structure towards you know, a different payment structure that would maybe insulate you if in times of financial pressure. So that's one thing, just a shameless plug for value-based care, I would sort of add as a closing thought, although recognizing, as has been said today, that there's is more research that needs to be done on, you know, exactly why you know, why some practices remain independent and others don't. So I want to thank our speakers here today. As I have said, and want to reiterate, we're so pleased that you were able to participate and share your research here with us. It has been very, I think, thought-provoking as we consider what the government's role, whether it's Congress or the administration, might be in moving forward with respect to some of the recommendations that they've put out there, and then some of the policy actions that could be taken in response to some of the research that you guys and your organizations are doing. So I want to thank you. I have gotten a couple questions about the slides. Assuming we get permission from everyone, we will go ahead and make those available. We will send them out in a link to everyone who registered after the event. Give us a day or two, but we will go ahead and get those out. So thank you for joining. Again, thanks to our speakers, and we hope to be in touch with everyone on these issues soon. Thank you.
Thank you.